Hi, welcome to Conversations in Interventional Cardiology. My name is Cindy Grines, and I'm the JSCAI Associate Editor and Chief Scientific Officer at Northside Hospital Cardiovascular Institute in Atlanta. I'm honored to present JSCAI and the Editor-in-Chief, Alexandra Lansky. Today, we're here to discuss a very important document published in JSCAI titled Percutaneous Mechanical Aspiration for Infective Endocarditis, Proceedings from an Inaugural Multidisciplinary Summit and Comprehensive Review. I'm joined by an esteemed panel of leaders and experts, including our presenter, Lucas Marinacci, who is a cardiology fellow at Beth Israel Deaconess Hospital in Boston. Molly Paris is a program director for Mass General Infectious Disease Fellowship in Boston. And Kenny Rosenfield is also here, and he's a section head for vascular medicine and intervention, the chair of the STEMI Quality Improvement Committee at Mass General Hospital in Boston. Thanks to all of you for joining me today. I'm going to turn it over to Lucas to start the conversation.
So thanks for the opportunity to discuss our work about the current and future role of percutaneous mechanical aspiration in the treatment of infective endocarditis. Here are my disclosures. So in this document, we talk about how the epidemiology of endocarditis has been evolving over the past decade. Patients with endocarditis are getting older with multiple comorbidities. Up to 40% of older patients with endocarditis have a valvular prosthesis or implantable device. And at the other end of the age spectrum, younger people are presenting with more drug use infected endocarditis and with a kind of high mortality being driven by repeat infections. And so while the cornerstone of our management kind of remains antibiotics and surgery, many of the patients that I kind of just discussed fall into this gray area where medical management alone may be likely to fail, but the risk of the surgical approach, either in the long or short term, is deemed to be quite high. So this is where endovascular catheter-based approach to remove infected material from either the right or the left side of the heart has emerged as an alternative or complementary therapeutic approach. So even though PMA for infective endocarditis has been around for more than a decade or in the literature, there's still kind of little consensus around its optimal use, and practice patterns vary quite widely depending on where you are and what type of hospital you're at. So I think this motivated Dr. Rosenfield, Dr. Paris, and their colleagues to organize and arrange this multidisciplinary summit consisting of imagers, interventional cardiologists, infectious disease doctors, addiction medicine specialists, surgeons, to kind of discuss the current state of the field and chart a path forward, and while also kind of coming to a consensus about what best practices might be. And so the paper that we're discussing is a product of that meeting. And so in the manuscript, we kind of had three main objectives. And at the patient level, we wanted to provide a clinical framework and review the evidence and kind of go through each of the scenarios that you might be considering this procedure. Then we wanted to examine at the system level how this intervention fits into the modern healthcare landscape in terms of collaboration, equity, access, and financial incentives. And then finally, at the organizational and professional level, we wanted to specify the challenges in the field and sort of propose some potential solutions moving forward on how to answer them. So to share some of the highlights in terms of our framework, we explained that there are three main clinical goals of percutaneous mechanical aspiration for endocarditis. The first is source control in order to remove an infected vegetation that may not be able to be cleared with antibiotics alone. Embolism risk reduction, similarly to remove a large vegetation that might otherwise embolize to the pulmonary systemic circulation. And in rare instances where it might change management, acquisition of a specimen for microbiological or pathological analysis without the need for surgery. So it's important to think about how these clinical goals fit into the overall treatment strategy for a given patient. So we propose this framework whereby you can think about this operation or procedure in terms of a bridge to surgery. As someone who is at high modifiable risk, in order to quote unquote buy time or stabilize them to get to an eventual surgery and allow some additional interventions for optimization in the meantime by reducing their risk of ongoing infection or embolism. The second is as an adjunctive management. The classic example of this is removal of vegetation immediately prior to lead extraction when there's a device infection. And then finally, as a destination therapy, there may be certain patients who are so high risk for surgery whereby this might offer them a viable alternative in order to avoid surgery altogether. Or there may be patients who may not be high risk for surgery, but nevertheless, because of minimal valvular dysfunction, this might be able to help them avoid or significantly delay an eventual cardiac operation. So to help link the goal with the strategy in each clinical scenario, in the manuscript, we constructed this algorithm for readers to consider when thinking about PMA for endocarditis. And in terms of our discussion in the paper about the role of PMA in our healthcare system, at the hospital level, we talked about the importance of establishing endocarditis teams, and specifically about the role that interventional cardiologists can play. At the regional level, we discussed the awareness of the procedure as a therapeutic option, so doctors consider it appropriately when treating challenging cases, and also the importance of creating referral networks whereby patients in the community setting can have improved access to the procedure. And then finally, we also discussed the current state of reimbursement and billing and the importance of advocacy in terms of keeping this financially viable for hospitals and physicians. And then finally, we explored some of the unanswered questions, which kind of span the care spectrum in the procedure. We still have significant work to do in terms of not just patient selection, but also timing of intervention. We do need to demonstrate adequate safety, especially in certain circumstances, such as when the subvalvular apparatus is involved, or left-sided structures, or when there's a PFO. And similarly, we need to better define both the technical and clinical endpoints of success. And then finally, and most importantly, we need to start tracking outcomes and performing comparative effectiveness research using everything at our disposal, observational data, claims, prospective registries, to guide the development of an eventual randomized clinical trial. So to take on these challenges, we do need to organize. And so we propose a consortium model similar to PERT that Kenny has kind of pioneered, whereby stakeholders can kind of work together to identify the priorities, secure funding, set standards, reduce redundancy, and start achieving the goals that we put forward kind of quickly and efficiently. So I'd like to acknowledge everybody who organized the summit to begin with, all our co-authors, my Smith Center colleagues and mentors, and I kind of look forward to seeing what you guys have to say. So thank you for letting me share our work. I appreciate it.
Okay, excellent. I'm going to start by asking Molly a question. If there's an increase in incidence of SBE in the population, do you think we need to modify the guidelines for prophylaxis? I mean, right now, when I'm as a cardiologist, I just think of valvular heart disease, specifically mechanical or bioprosthesis, to be have prophylaxis. But should we expand that? Lucas talked a lot about leads. Do we need to give SBE prophylaxis for anybody with a pacemaker lead? What are your thoughts on that?
It's a great question. And what I will say is, I think some of the more recent guidelines, particularly those published most recently in the 2023 European Society of Cardiology guidelines, really highlight that because of the increase in cardiac hardware that's being placed, we may need to start reframing how we think about risk and particular interventions and things like that that may actually require more antibiotic prophylaxis. So it used to be sort of cut and dry. These were the scenarios fairly clearly as to what indications there were for, namely just dental prophylaxis. But actually, the European Society of Cardiology guidelines that were published last year actually seem to have expanded that a bit and have highlighted a few other interventional procedures specifically that may make one consider whether or not antibiotics need to be prescribed in those settings. And so I think it is a balance very much between the risk of overexposure of antibiotics in the larger population and thinking about the risk of someone who actually does have cardiac hardware in place and therefore would be at an increased risk for a cardiac device or prosthetic valve related infection. And I will say, I think it'll be interesting to see how this changes over the next several years in terms of studies coming out, if they're using the new framework for thinking about antibiotics with these procedures with cardiac hardware in place, and how that might impact the rates of the cardiac hardware related infections. So it's an excellent question.
You wouldn't change how you're using prophylactic antibiotics?
At this point in time, I certainly currently stick to the current guidelines. I do have patients who have had repeated episodes of endocarditis related to their prosthetic valves, and in those scenarios, just because of the number of times that they've had that, I will be more intensive and intentional about prescribing antibiotics for other procedures that might not normally fit into the guidelines. But that's on an individual patient basis and not necessarily broadly.
Right. Kenny, did you have a comment?
Just that the incidence is so low of valvular infection associated with this huge increase in prosthetic valves and so on. I would imagine it's going to be hard to document, to document the exact rate of infection and whether, when and whether it's appropriate to use antibiotics. I can't imagine. I think that's why the dental prophylaxis thing stopped, is because there weren't data to support it. And I'm just wondering, what we're going to need to do to prove that it's important to give antibiotics and when. It's a challenge, I think. Although the numbers are so high now in terms of, TAVRs and mitral valve repairs and replacements and so on and so forth, and now tricuspid, that it's going to be, maybe there'll be enough to demonstrate a difference between those getting versus those not getting prophylaxis.
Right. Okay. Lucas, you breezed by that algorithm very quickly, but I think from the standpoint of the JSCAI readership, we'd like to see that in more detail. Could you pull that back up? And then Kenny, while he's doing that, can you comment on the risk of embolization doing these procedures? Do we have any data on that?
Well, we don't. It's a great question. And I think some of it is, a lot of it is lesion dependent. A lot of it is device dependent, which device you use to remove the material, and a lot of it is operator dependent. But generally, we have not seen a significant, at least in my experience and in the registry that Lucas and others involved in this have developed, have not seen a significant morbidity or mortality from embolization to the lungs. And the lungs there's definitely some that happens, we know that, but I don't think it's as big an issue. I get concerned, I'm just going to be partisan here a little bit. I should say at the outset that this summit that we had in Boston, which was fantastic, there were about 15 people there, some from Europe, some from the US, some cardiologists, some cardiac surgeons, and Molly and some of her colleagues were there. It was sponsored by AngioDynamics. They were kind enough to recognize the importance of this. I'd been pushing them for years on this, and of course they make the AngioVac and the AlphaVac catheters, which are two devices that can be used. Inari also makes their FlowTriever, which has been approved for this indication as well. I like the continuous suction aspect, so that anything that is loosened up or suddenly becomes free gets withdrawn immediately, rather than sort of pushing things around that you have to intermittently suck on. So we'll see. I mean, I think the devices are in evolution, but I think embolization's not been a big issue, Cindy, so far.
Mm-hmm. Okay, that's good. So Lucas, maybe we could start with the right-sided endocarditis, because I think most of us would feel more comfortable approaching those lesions.
That's fair. And I feel like this is the most common thing that comes up in clinical practice, and certainly at Beth Israel, where I am. So I think the most important first step is really considering, what is going on in the heart right now, and recognizing that PMA or this procedure is really not going to do anything if they have decompensated RV failure from acute tricuspid regurgitation. If you have significant heart failure or valvular dysfunction, ultimately, this is not going to fix the underlying valvular lesion. So if that's the main indication for surgery and the main reason why they're decompensating, then really this probably is not the procedure of choice, and you should really be thinking about a primary surgical approach regardless in almost all those circumstances. Similarly, if they have a local complication of infection, which isn't very common on the tricuspid side, but if they do happen to have an abscess or fistulization or something that is more complicated, that does not need to just be removed but also repaired, again, PMA is not going to be your first line option here, and is most likely inappropriate. So I think it's important to highlight those points. That's not to say that there aren't certain clinical scenarios whereby I discussed as a bridge to surgery, sometimes a two-stage procedure is helpful, but I would say those scenarios are quite rare. So the most common reason that people, I feel like we consider this are two. The first is if patients' blood cultures do not clear and the primary source is thought to be the vegetation. So this is when the infectious disease colleagues are very helpful in terms of helping us figure out, oftentimes these patients have emboli to their lungs and they have some significant emboli burden and potentially infection there. And that may be driving positive cultures and fevers. So really attributing it or thinking that the vegetation, usually because of its large persistent size and ongoing bacteremia, is the source, then we often consider PMA in that instance. And oftentimes as well, if the underlying valvular dysfunction is not significant, as I mentioned, this might be sort of one and done destination therapy whereby the aspiration plus the antibiotics are enough in order to avoid surgery altogether. The other main reason is if patients are continuing to have septic emboli and they have a large residual vegetation. Oftentimes, these patients have ongoing respiratory compromise. We have had cases where patients are hemodynamically impaired, not from valvular dysfunction, but because of the burden of septic emboli. So removal of the residual vegetation, we believe, might reduce the risk of another embolization that might, quote unquote, put them over the edge and require intubation, or may cause hemodynamic collapse from another pulmonary emboli insult. So again, in this instance, PMA may be able to offer a, quote unquote, destination therapy. Or if they do have multiple lesions, it still may be appropriate to stabilize them, clear their cultures, or avoid future embolization with the PMA, and then after that, consider whether or not you can make them a better surgical candidate. Finally, on the right side, again, in a rare circumstance, if specimen sampling has significant management implications, such as culture negative, and it would guide antibiotics, or we're not quite sure if it's infection or not, and making that distinction is very important, you can help avoid doing a sternotomy and get a direct sample. On the left side, it's less common, but certainly done in certain areas of the country. Kenny can probably speak to this better than I can, but I know our colleagues at Henry Ford, for example, are doing this on a more regular basis. But it's very similar in the idea that, if you have decompensated heart failure from a valvular disease or local complications, this isn't your best choice. But if there is concern for risks of embolization, uncontrolled infection, or very resistant bacteria, or a vegetation that's not getting better with antibiotics, again, this might be appropriate consideration, especially in those who are deemed high surgical risk, because otherwise most of these patients would pretty definitively otherwise get surgery. And then finally, in the lead situation, these are stronger in terms of the guideline recommendations, especially from the ESC, where if you have a large vegetation and you're planning for a transcatheter lead extraction, which is the most common way to remove leads in the current era, if the lead vegetation is large, or if there's a concomitant PFO, there's evidence for removal of that vegetation in a basically simultaneous procedure immediately before transcatheter aspiration or removal of that infected lead. And then two smaller points, which again, Kenny might be able to comment on. Before all these cases, we tend to do, if we're not getting a TEE, we will do a TTE with bubbles to make sure or to assess whether or not they have a PFO, because that might play into our risk-benefit decision. I wouldn't say it's an absolute contraindication to the procedure, but it certainly plays into whether or not we think the safety and the approach, as Kenny was mentioning, whether it would be a continuous aspiration versus a manual suction. And then finally, there's an ongoing discussion about, if people have a stroke or an aneurysm, generally this requires heparinization for a target ACT of 250 seconds. But, for the alpha vac approach, this might be quite minimal, especially if there's not continuous suction in a circuit. So this is a case-by-case basis and something we need more evidence on, but certainly that plays into the decision-making.
Well, thank you. Molly, what do you think about this and the team approach?
Yeah, I think Luke has done an amazing job of kind of highlighting the various discussions that go into considering this particular type of an intervention in this setting of an infective endocarditis. And I think more than anything, what the work that we've done has really highlighted the importance of a multidisciplinary approach to the care of this patient population, which is, really should be standard practice. It's a group effort between our primary teams, our infectious disease colleagues, our cardiologists, including interventional cardiologists, as well as cardiac surgeons, and any other subspecialists that need to be included. If it's a drug use associated infective endocarditis scenario, then including our addiction medicine specialists is absolutely essential to make sure that we're getting underlying control of the patient's substance use disorder. If there has been a stroke, getting our neurology and neurosurgery colleagues to weigh in as to the safety of these types of procedures, just as a few examples. And so I think it's really wonderful to see this all come together, but it really does take a complete team approach when thinking about the care of this complex patient population.
Okay, excellent. And Kenny, I'd like to ask you about the lesion morphology. I noticed that, we're looking at greater than 2 centimeters for the right, greater than 1 centimeter for the left, but does it matter what the lesion looks like, where it's located? Is it whether it's pedunculated and mobile? Could you comment on that?
Yeah, sure. There are a host of different morphologies that we look at, and that's also part of the consideration at our duet team meetings. The thing that Molly created, I'll just make a comment on that. The duet team, it's called drug use. What is it? Drug use endocarditis. What?
Drug use endocarditis treatment team. Treatment team,
but honestly, it's all endocarditis really that we deal with that team. More than half of it is probably drug use associated endocarditis, but and I'm just going to underscore before I answer your question, Cindy, underscore the importance of that. These are really complex patients, and what I, as a proceduralist, my first encounter was, oh yeah, these are cool procedures. We can take off these little lesions, and the valves are preserved. Actually, that's a comment to make, is that we usually the tricuspid valve usually is not affected in a negative way. It's usually actually positively affected, but it all is not about the procedure. It's all about the patient, and as always is the case. And I've been so enlightened. My eyes have been opened by interacting with, in particular, our addiction medicine people. I mean, it's just amazing how they approach these patients, and they're thinking not about the short term, just taking out this bug on the valve. They're thinking, what do we do to prevent these things from happening? Is this patient appropriate to undergo any procedure at all? And on and on. I mean, these are so important, these factors, and I would encourage anybody who's thinking about doing this, that they need to be part of a team-based approach, much like the PERT effort, but even more so in these cases. So as far as the lesion morphology, I mean, we always, if there's something that's mobile, that's kind of hanging on by a pedunculated, a thin stalk or something like that, that's moving back and forth across the tricuspid valve, we obviously get more worried about those things embolizing, and they often do embolize. They often are showering off material into the lungs. The ones that are adherent to the wall of the atrium, for example, that look like they're more chronic, they're much more challenging to get out. I think about this procedure as on the tricuspid side, or the valve, the right side, as debriding the tricuspid valve. Really, it's a debridement that I'm doing, it does take a certain level of skill and experience. And I think, if people shouldn't be doing it for the first time without actually sort of speaking to others who've done it before, because there are certain approaches that make it easier. For example, it's much easier to debride the tricuspid valve coming from the IJ than it is coming from below. It's much more challenging to get out to the tricuspid valve and to, cover the entire span of material that's hanging there from below. Not that it's impossible, but more challenging. So these are some of the little factors, Cindy, that play a role, but a lot of factors go into deciding whether or not to do it and how to do it.
Right. I'm sure it's very, very challenging regardless, and it's helpful to have put a lot of heads together in the multidisciplinary approach. So very impressive. I want to thank all of you for participating. Lucas, it's an amazing paper. Congratulations. And Molly, your insight was very helpful. And Kenny, as always, I really appreciate you helping us out with your insight. Thank you very much.